Hi, welcome back. For those of you who checked out the other two videos as part of the series, you can tune this part out. This is just my friendly introduction and an introduction to the video. If this is you just joining us, let me introduce myself and let me also invite you to check out those other two videos. My name is Amy Ellis. I use she, her pronouns, and I have my doctorate in clinical psychology. I'm an assistant professor and the director of the Trauma Resolution and Integration Program at Nova Southeastern University. There we run a clinic that is entirely staffed by doctoral trainees who see often prolonged and repeated survivors of trauma, but certainly we see all different forms of trauma in that clinic. So today's video is going to focus on really understanding what we mean when we say trauma-informed or trauma-focused. In fact, I'm nearly certain I've used those words throughout the other two videos, and that can be pretty confusing. And then also really understanding how that's tied into minimum competencies and standards. And unfortunately, I'll skip to the punchline, how oftentimes our mental health providers are not adequately trained and proficient in providing trauma treatment. So, like I said, we often throw out the terms trauma-informed and trauma-focused. What does each of those mean? So when we talk about being trauma-informed, it means that our goal is to understand the impact of the trauma on the individual, on their functioning. We want to resolve some of that trauma, and we want to develop skills for healthy integration. Trauma-informed is an approach. It's not an intervention. I actually joke that this is the approach that you should take when you're going to the grocery store and you're standing online for the cashier and someone cuts right in front of you. Taking a trauma-informed approach means that you're just trying to understand the impact. You're trying to understand that person. You're not assuming malevolence. You're not assuming malintention. You're kind of just approaching things with this, okay, let me understand. Let me not jump to assumptions. So we can be trauma-informed outside of the therapy room. We always want to be trauma-informed. Trauma-informed also is guided by the New Haven trauma competencies, which I'll review in just a second. Trauma-focused, on the other hand, in order to be trauma-focused, you do need to be trauma-informed, but the goal is primarily to resolve trauma. It is an intervention. It's a series of interventions. It includes things like our evidence-based treatments like cognitive processing therapy, prolonged exposure, EMDR, and it's guided by the APA, or the American Psychological Association, PTSD treatment guidelines, and we'll get there as well. So let's start with the New Haven Trauma Consensus Competencies. This was a conference where they brought in 60 experts, luminaries in the field of trauma, and they had everyone kind of sit down at these tables and do these powwows of what are the competencies that we expect for a trauma-informed provider to have? What do we expect in terms of like the minimum set of expectations and competencies for trauma-informed assessment, trauma-informed knowledge, trauma-informed intervention, trauma-informed professionalism, and trauma-informed relational systems. Okay. Again, these are minimum expectations, and what I have here is really just kind of our cross-cutting competencies, our summed up New Haven consensus statement. And so what we know is that in order to be a trauma-informed provider, we need to understand trauma reactions and then tailor our treatments and assessments accordingly. We have to account for developmental lifespan factors. So if you checked out video 2, you'll understand that there's a lot in terms of development and family environment that's going to influence how somebody manifests post-traumatic stress reactions, how somebody responds to therapy, how somebody engages in that therapeutic relationship, and so on. To be trauma-informed, we have to integrate survivors' strengths. We have to facilitate their shared decision-making, essentially being as collaborative as possible, empowering the individual, not usurping that power and control. We need to understand how trauma inevitably, when it's relational, is going to impact safety and trust. How to be a trauma-informed provider, we need to self-reflect. We need to practice self-care. We need to be self-aware. And we need to stay up to date on current research and all of the research-supported therapies. It's not an excuse to say, I just didn't know. And ultimately to work in a collaborative space with other providers and other systems. So to be trauma informed means that you're approaching an entire system. You're approaching things from the whole individual, from all of the different disciplines, and you're really tailoring and making treatment as nuanced as possible. What do we mean by trauma focused? Well, these refer to those interventions that I mentioned before. As we know, the typical recommendations put forth by the American Psychological Association was that there are certain guidelines, things that just showed more evidence for being more effective in the treatment of PTSD. And those include the top 5 of prolonged exposure, cognitive processing therapy, EMDR, narrative exposure therapy, cognitive behavioral therapy, etc. I'm not going to get into a lengthy discussion about each of these, but I did want to kind of take apart PE and CPT as just 2 examples. So where prolonged exposure really focuses on the goal to confront fear stimuli, it's an emotional processing orientation. It's 10 to 15 manualized sessions. They're 90 minutes each. The purpose is that you're exposing an individual repeatedly and over to imagine what event had occurred and systematically desensitizing them to having that very strong visceral reaction. It also has a second component where you're not just doing those imaginal exposures, but also including real life or in vivo exposures. So encouraging someone to confront things that they might be avoiding in their real life. Let me be clear. If someone was sexually assaulted, the goal would never be to confront in vivo in real life that perpetrator. Instead, it would be to maybe go back to the alleyway where that sexual assault occurred and cope with and process those feelings of anxiety and post-traumatic stress there. Cognitive processing therapy, very similar, but it uses more of a cognitive behavioral approach, and it encompasses 12 manualized sessions. It could be either individual or group. The goal is to express emotions and identify stuck points, or these maladaptive cognitions that seem to be holding someone stuck in this pattern of re-experiencing and feeling those post-traumatic stress reactions. An example of a stuck point might be something like, what happened to me is my fault, and if only I could have done something differently, and I should have done something differently to prevent it from occurring. So in sum, these trauma-focused treatments all share a commonality. They're all targeting the symptoms of PTSD directly, and they all include some sort of exposure component, right? We're going to expose you to the thing that makes you really scared, and we're going to hopefully reduce that. And for the most part, we know that that works, right? Like, I can tell you that when I'm treating somebody who is scared of spiders, and then they have to go and become an exterminator, that's going to be impairing. They can't just keep avoiding spiders. So what do we have to do? We have to keep exposing you to them so they don't carry the same kind of weight and frightening merit that they used to. But I feel like I'm always the negative Nancy. There's a few issues with this. The issue around the evidence-based treatments that have been recommended by the APA is that they're largely based on empirical studies and using studies that follow a randomized controlled trial design. That means that they are looking at prolonged exposure or CPT, and they're comparing it to a wait list or treatment as usual. That's awesome. That's like our gold standard of research. In our previous video, though, we talked about how complex PTSD treatments may require some more tailoring and certainly do not take 12 sessions. We're talking at minimum probably a year, but likely more than that. So we're not really getting a full picture of what it might look like for folks who are complex trauma survivors. That's okay. Okay, fine. So we're just going to look at this in isolation. It's just PTSD. Okay. But we also know that individuals who have PTSD have 80% of those folks have a comorbidity with another disorder. Unfortunately, when we're looking at RCTs, we want to control as many different factors, and a lot of RCTs are going to exclude people who have other diagnoses, particularly active suicidal ideation, active psychosis, or an active substance use disorder. So now what we've got is research that shows that this treatment works compared to another treatment that is probably of lesser value, kind of like what we're doing as already, but only for people with just PTSD. They've got no other comorbidities. They have no other sort of struggles. It's helpful. It certainly tells us about a subset of people, but does it really give us the full picture of what the most effective treatments are, because we've ruled out so many other people? Another issue with this is that in the context of the New Haven trauma competencies, which tells us to be trauma-informed practitioners, and we're thinking about how to modify and be nuanced and tailored to the individual, well, a lot of these treatments are manualized and actually emphasize following the manual as closely as possible to have more fidelity to the approach. So there's more that meets the eye. We don't necessarily want to just say, these are the top treatments and that's the only thing that can be done. We should take this with a grain of salt and potentially use some of the active, mechanisms of change and integrate them into our treatment. We really want to make sure that this is a collaborative process and clients fully understand what they're doing in trauma-focused treatment. A lot of times clients will say, I just need to process my trauma. I know that's what's hanging me up. I know that's what's holding me back. And I like to engage in a discussion of, hold up, let's make sure that we're communicating the same way. There's trauma processing, and then there's trauma processing. Or in other words, there's formal trauma processing and informal trauma processing. And I make the distinguished remark that formal trauma processing refers to the 5 evidence-based interventions. We're kind of very closely following this intervention and this manual. It's formal. Informal trauma processing is really just what I mean when I say that I process anything, right? So I process the client's emotions about their work relationship. I process feelings around their view of their self in regards to their childhood environment. So certainly we can do informal trauma processing, and many of our clients are often asking for that. They don't actually mean formal trauma processing. They might mean more informal routes. I just want to talk about how the trauma has impacted me, my sense of self, my relationships, my ability to succeed and be motivated, whatever it may be. I don't want to feel like I have to dial that back and I have to be silenced. Okay, so that's a really important conversation. This also leads us to really question, why are folks coming into therapy feeling like they can't talk about certain things? And that's really where our conversation comes in around training and competency. So what we do know is in investigating psychology doctoral programs, only 1 in 5, 20% of programs, say that they have a course specific to trauma and they offer a specific trauma practicum. That is like the most bare expectations possible, right? I don't want to go to a medical doctor who has maybe taken 1 course on colds and flus. Clearly not a doctor, not a real doctor. I don't want them to just go to 1 of those and having, maybe gotten put into a practicum where they saw colds and flus, right? I want to go to a doctor who has studied this extensively and who knows the latest treatments and maybe has seen this before, etc. Then you consider, we're lucky if we get those 20% at the bare minimum. What about the 80% of folks who have never, ever learned about trauma? The 80% of folks who have never actually worked with a practicum or an internship experience where they got supervision from somebody who understood trauma. But yet we juxtapose that with the fact that we all know trauma is out there, right? Multiple people are experiencing potentially traumatic events. These are high rates of exposure, and there's high rates of prevalence of PTSD. So we're working with it, but maybe we don't have the training and the background for it. Really kind of speaks to how we need more continuing education. We need more involvement. And so I'll obviously make a plug for some of those outlets. If you're a mental health practitioner or maybe even a peer who's working in this field, you should check out some organizations like the American Psychological Association, their Division 56 for trauma psychology. There's also different divisions in the American Counseling Association. There's the International Study for Traumatic Stress. I'm going to butcher that. ISTSS and ISSTD. We'll make sure to include those links that also focus on trauma and dissociation. These are ways to kind of stay relevant with the current literature, learn some of the nuances of treatment, and also get some case supervision when we're working with this. I do feel, even though I can't do an extensive training here on all the things that are trauma, I feel like maybe I can instill just kind of this sense of what it means to be a trauma-informed practitioner. So as you see on this slide, I've actually included a few other components. I'm going to encourage us to not just be trauma-informed, but affirmative and social justice-informed. If you actually look closely, they're all the same thing. That is my hypothesis here. To be trauma-informed, you have to take a social justice-informed perspective. To be trauma-informed, you have to be affirmative. If you're not, if you're someone who touts themselves as being trauma-informed, but you're not being aware of and advocating for and supporting our LGBTQIA plus individuals and community, if you're someone who says that they're trauma-informed, but doesn't think that people of color are at disproportionate risk for trauma based off of chronic experience of stigmatization and discrimination, you're not trauma-informed. So to be trauma-informed means that you're being responsive to someone's entirety of their identities. In one of the other videos, I showed you Simpson's model. It's really about understanding who the individual is and how they react in their systems and their world. Being trauma-informed means that you're exploring and addressing the impact of trauma on development, on sense of self, on physical well-being, psychological, emotional, etc. Being trauma-informed means taking a strengths-based perspective. This is not a pathology-based one. My clinical psychology folks, you may struggle with this a bit. My counseling psychology folks, lean into it. It's about leaning into the power of what people are capable of, their resiliency, and fostering strengths, not seeing deficits. It's a model in which we bring compassion and we focus on empowerment, because across the board, whether we're talking about someone who's been traumatized big T or traumatized little t with experiences of discrimination and stigmatization, the fact is that it's collective experiences of being minoritized and disempowered. And so that needs to be a focus. Another aspect is focusing on collaboration and permission and choice. So it's not us conceptualizing why someone has the issues that they have, but pushing them to conceptualize why they have the difficulties that they do. It's not us saying you have to do XYZ treatment. It's inviting choice. You could do XYZ, ABC, and so on, and giving pros and cons and helping people to make that decision for themselves. There's also, to be trauma-informed, this idea that we assume nothing in a good way. We assume that there's no default. We don't assume that someone is heterosexual. We don't assume that somebody doesn't have an experience of trauma. We don't assume malice. We don't assume anything. We assume that the person is doing the best that they possibly can. And of course, we can all be doing a little bit better. I borrowed that from DBT. It's one of my favorite mottos, though. To be a trauma-informed practitioner means that we see that nobody is intentionally doing something wrong or hurtful or manipulative, but maybe based out of a lack of skill or knowledge or ability. And so we want to take this approach of asking, being inquisitive, really inviting people to share their experiences rather than us telling them what their experiences must be like. And ultimately, across the board, we have to tailor our interventions. That's a lot. So what does it all boil down to? A trauma-informed, affirmative, and justice-informed, social justice-informed individual is in part a relational and interpersonal approach. It's one in which we're approaching relationships with the intention of fostering safety, trust, choice, say in the relationship and the work that's done, collaboration, and empowerment. And it also includes therapist components, like the therapist choosing interventions that can be choices and tailoring those treatments, also the therapist being able to self-reflect and to be able to acknowledge biases and gaps. One of the things that I personally have moved away from is I used to say, I'm so culturally proficient. I'm not, but I strive to be, because there's always something that I can be learning, whether it's about trauma or minoritized identities or social justice issues and so on. So I'd encourage also taking that approach. When you boil it down, to be trauma-informed means you're taking away from the question of what's wrong with you, and you're just asking what happened to you. And I think that's such a pivotal kind of mind shift to understand that trauma-informed assumes that things have happened, not that there's some sort of pathology or aspect that's wrong within an individual. So as we wrap up in this third part, what we've talked about today is really understanding the differences between trauma-informed and trauma-focused approaches. We've understood how those are influenced by different competency statements and consensus statements and guidelines. And so there's a lot of stuff kind of building around this for our understanding. And we understand that training is lacking. We often don't have this. So if you're a mental health professional going, oh gosh, I was from one of those programs, I never got a course, I never had a practicum, that's okay. There's still time. There's lots of conferences, there's lots of webinars. And it's our duty as trauma-informed practitioners to expose ourselves and to attain that information and knowledge. We also covered the primary components of being a trauma-informed, affirmative care, social justice-informed practitioner, and how it really involves a complete mind shift. I invite you to check out some of the other videos in this series, which talk about the definition of trauma and our understanding of the diagnostic implications, some limitations there. We also have a video on understanding adverse childhood experiences and the necessity of really going broader than just the individual and even the family environment to understanding macro system factors. Thank you.